Well, good morning, everybody. Excuse me, I'm a little bit under the weather. Uh, I'd like to introduce Shane Busted, who is somebody who I've gotten to know over the last probably 7 months when we started working on buprenorphine and training. He was part of our system here for a little bit, helping us with training with both the EMTs and the protocol and everything else. He's a well-known speaker, educator, as well as a fantastic doctor. But I'll let him introduce himself and give his own little introduction. So Shannon, welcome. I appreciate you spending some time with us.
Yeah, thanks everyone. So Shannon Bosted. I'm a family doctor. I've been in Bellingham since 2011, working at CMAR. And over the last few years, I've expanded to primarily be focusing on addiction medicine, but in a number of different avenues outside of direct patient care, including education. Um, Mostly my practice for addiction medicine is opioid use disorder, but unfortunately, the stimulant use disorder is becoming a larger and larger part of the lives of the people that I care for, and probably that you will be seeing as EMTs. So, I luckily I get to work with the Opioid Response Network, which provides some extra resources so that I can give talks like this to you. So with that, I would like to introduce Sarah Canavisi, who is one of the technical assistants for the Opioid Response Network. Sarah.
Okay, first and foremost, can you see the proper screen for the presentation? Is it the weird screen with the things? Yeah, that's what I thought.
Yeah. Do
Go
I
ahead.
do I do I need to share the host with you? Is that well? You should be able to do this.
Yeah,
Uh, Put it up.
let me try again.
Okay.
Now is it the right screen?
Yes.
Awesome. Hi, my name is Sarah. I'm the one that kind of helps when these things happen. Sad that it's happening to me. So, I am with the Opioid Response Network. We are a SAMHSA funded grant and we provide technical assistance. We do focus on opioids and stimulant use disorder, and we are have been around since 2018. The work that we do is pretty exciting. And if you guys ever feel like you might need help with any sort of trainings that fall under opioids or stimulant use disorder, you are more than welcome to submit a request through us. We do all of this free of cost to you. And with that, we're getting ready for the presentation. So Dr. Bosted.
Great. Yeah, I have no disclosures. Go ahead. So today, the main things that I wanted to focus on are just kind of a broad overview of psychostimulants and how they play a role in the overdose epidemic. Talk about disparities that are very important to know about who is more or less affected by stimulants. I'd like you to be really clear on what stimulant intoxication and overdose look like, because that is a life-threatening emergency, and it's really important to have a sense for what the presentation is going to be. Also talk a little bit about withdrawal, because that has its own relevant difficulties. I think it's important for you all to know like the basic medications that we might use both in the acute setting and then also on an ongoing basis for treatment of stimulant use disorders. And then also some behavioral techniques, again, that you can use when you're addressing someone who is in the midst of an overdose event, and the things that we kind of do afterwards as well. As far as the objective goes, don't worry too much about the contingency management. I'll describe that in a little bit of detail, but it's not going to be particularly relevant to the work that you guys do. And then we can also talk about common comorbid medical and psychiatric conditions that you'll see. Okay, yeah. So the epidemiology, keep going. So this is important. This is an older slide, but it's important to know. We've all heard about we all know that opioid overdoses have been such a critical event in the life of our community, our families, our country. And it's really important to see here this slide. So blue is the number of deaths over time that are related to fentanyl, where that's the main thing that is in their system. But right up next to that, fentanyl overdoses with stimulants involved. So you've got this a lot of folks who use fentanyl are probably also using stimulants. The converse, interestingly, is not often true. People who have a true stimulant use disorder, they have a much lower percentage of using other opioids. And it's a little bit easier because the methamphetamine and cocaine supply is less contaminated than fentanyl. Fentanyl is extremely cut. It's got a number of different chemicals that are added to it as fillers because it's so potent that if you don't add a lot of fillers, then you're going to have a lot of dead people that are taking your drugs. So, but the same is not always true about meth and cocaine. So go ahead. So with this slide is pretty similar. It mainly talks about the fact that there's lots of stimulants that people may use and the kind of percentages in all of those categories. It does look like you can see from 2010, 77% of the overdose deaths were not related to fentanyl or stimulants versus 2021, that percentage has dropped to 16%, meaning that opioids or methamphetamine are the main drivers of overdoses in the recent increase. One thing to know is that this is through 2021. Since 2023 seems to be the high point of the overdose numbers in our community, and it has since fallen off a little bit, which probably entails, fewer EMS calls, specifically about overdoses, things like that. I understand that a lot of it now, you may get calls for people who are post resuscitation. They've already been opioids have already been they've already had that overdose, and then you guys get called. Go ahead. So this is through 2004, this 2024, this is just what I was saying before. Things are finally coming down overall for opioids, although a little bit slower for methamphetamines, and in our region, less for cocaine. Continue. Kind of the same information, and I think Steve can show you this if you guys already don't know it, but perhaps you guys are already well aware of all of this. But basically just showing that the numbers are much lower than the peaks that we saw in 2023. Go ahead. This is the most up-to-date data from the state website on overdose data, which shows a pretty significant decreases again in overdoses. That's interesting that last one for emergency department visits dropped off, but we can just still see EMS responses. 3,813 is a lot of responses for overdoses. So continue. Geography matters. This slide basically shows where things are happening. So anywhere that there's orange to red, you see that's a higher number. Anywhere where it's yellow or less, that's a lower number. What you can kind of tell from this, basically, on the left side at the top, methamphetamines are, most of the country, less in the Northeast, but cocaine is mostly in the Northeast and less in other parts of the country. Prescription opioid deaths have dropped off. There's almost no heroin anywhere in the country. And then, interestingly, this blue for alcohol, but it's important to remember that alcohol is a very, very common chemical and a common reason for people to have significant medical conditions. So I always like to highlight that. Go ahead. This is kind of showing the same thing. So you can just kind of skip through these. These are, yeah, okay. So this is important. The reason is this shows the percentages and the rate per 100,000 people of a given ethnicity who are affected by methamphetamine use and methamphetamine use disorder. And I think the main thing is that you can see all of these groups are rising, and this is just since 2018, this slide, and it's only gone up since then. But there's a huge disparity here. So the American Indian population and Alaska Native population have seen dramatically higher rates of stimulant use disorder and methamphetamine and cocaine related overdoses for both women and for men. Okay, go ahead. Other affected populations are the homosexual, gay or lesbian, and bisexual communities versus heterosexual communities. And all of these slides, the black bar is heterosexual, the middle bar is gay or lesbian, and bisexual populations are the white on the right. So down at the bottom, it goes medical use of prescription stimulants on the left, so that's things like Adderall, amphetamines. Non-medical use of prescription stimulants, so prescribed versus unprescribed, and those are not, totally dissimilar numbers for men. And illegal stimulant use is on the right, and what you can see is that in gay and lesbian and bisexual communities, the rate is much, much, much higher, and that holds for both men and women. Go ahead. Okay, so this is really important. While many people are starting to become more aware of opioid use disorder and potentially how it is a medical condition and how medications are used to treat it, there is less of that understanding regarding meth, and I think that there's a number of reasons for it. But go ahead. One of the reasons is, we see a lot of portrayals in popular culture that are very unkind to those who are suffering from this medical condition. So, you can see these things, your face is a meth, these kind of before and after pictures, showing like the effects of kind of a hard life and maybe direct toxic effects from methamphetamines. But one thing you don't show, you never see things like that for diabetes or cancer. So this is just good to remember that this is, that these sort of things make it feel as though people who use methamphetamines are monsters, and they're not. They're people who are affected by a medical condition. Okay, go ahead. So another thing that's important is, especially as you're in your training, getting used to using different vocabulary when you're discussing people who may be using stimulants or other substances, because what you say matters to other people, but also to yourself. So it's really easy for people, tweaker, junkie, crackhead, because you're seeing maybe similar behaviors in people, you're seeing kind of behaviors that you find distasteful. And it's important to remember that this is a person who has a problem. It is not a person who is a problem, because everyone can run into trouble with substance use. So just as it says, instead of addict, say a person with stimulant use disorder. Instead of talking about like a baby as an addicted baby, or a crack baby if it's born to a mother who's been using substances, they're a newborn with substance use exposure. If you see someone who's struggling with the psychological effects of methamphetamines, one of those effects is there's psychosis and paranoia, and I'll talk about that a little bit more, but we often see people and they're tweaking, they're crazy, they're aggressive, they're violent. And it's important to remember that these are a reflection of the fact that they are having an altered perception of reality that is different than yours. The things that they are experiencing are real to them. And as a result, they are exhibiting behaviors that are protective. So they may be extra paranoid, they may be fight or flight sort of in that mindset. So as you're working with them, please remember that these are people who are extremely scared. They are responding to different kind of stimulus than you are, and hopefully that will help you have a less confrontational interaction with them. Go ahead. So the basics of stimulants. So there's lots of different kinds of stimulants, everything from coffee to nicotine, cocaine, amphetamines, and then there's a few other ones. Khat and betel nut are common in other parts of the world. Synthetic cathinones are also called bath salts. But all of them have similar properties. They all affect the dopamine system along with some other neurotransmitters, and they all have a couple of clear effects. So they cause an increase in attention. They cause people to have maybe a rapid heartbeat. They cause euphoria. There's reasons that people use these things, but then they can also cause things like mood swings. They can cause rapid heart rate, even things like chest pressure or cardiac disease. They can even cause things like stroke eventually. Go ahead. This is mediated through, as I mentioned, the dopamine system. So we don't have to get into the weeds on this, but basically, as I mentioned, methamphetamine and cocaine are effective on nerves that transmit dopamine. Dopamine is transmitted throughout the body. So when someone, the normal system is there on the left. So the little balls are dopamine. And as you can see, there's like a little bag that contains dopamine. It is being pushed out from the upper cell into the middle between those two greenish things that are the nerve cells that are touching. So you've got a synapse there. The dopamine is released. When it's there, it hits receptors on the other neuron, and then once it sits there, a signal is transmitted that causes different things to happen depending on where it is in the body. So at those same receptors, cocaine interferes with the body's ability to recycle dopamine to continue this process. And what that means is there's more dopamine sitting in that area. So you have an increased amount of stimulation of that other neuron. That's about 10 to 50 times stronger signaling than with the normal things that may cause dopamine to be transmitted. Now, methamphetamine is up to 1,000 times more dopamine release than normal, kind of normal stimulus that can affect this. So yeah, you can ask me more questions about that later, but that's the main thing. Dopamine is released, and that has significant effects throughout the body, and methamphetamine causes a much, much, much stronger signal in these neurons. Go ahead. So an important thing to know is that with stimulant use disorder, there's a number of things that we know cause or are related, highly related with the use disorder. So this is something called ACEs. So ACEs are adverse childhood experiences. These can be a lot of different things. They can do to like physical or sexual violence. They can do to growing up in an unstable environment or not having anyone around who feels safe. Homelessness, being in a war zone, things like that can cause these sorts of things. Importantly, the two most common things that are associated with stimulant use are sexual abuse and substance use in the home. So just remember that when you're interacting with someone, there's a really high likelihood they've had some trauma. So this slide shows increasing numbers of these adverse childhood events that someone may have experienced. So blue is 0, so people didn't have any of those problems. Orange is 1. Gray is 2 or 3, and then yellow is 4 or more. And along the bottom, going from left to right, it's like increasing amount of use. So just as a real simple thing, on the left side, look at the yellow. So that means that's a very high number of adverse childhood events. And there is a significant overrepresentation when the more stimulants someone's using and the more likely they are to be addicted. So someone who's had 4 or more, like a third of the people who may use stimulants do develop a stimulant use disorder. And in some populations, it can be up to 50% of the people that are using methamphetamines will develop a substance use disorder. So go ahead. So what do we mean by a use disorder? Basically, there's 4 different boxes to be thinking about. Impaired control. So people may be using more often. They're trying to quit, but they can't. They're spending a lot of time trying to get the drug, using it, or recovering, and then they're also experiencing cravings and urges to use. It can cause problems with their relationships, so they're neglecting responsibilities, they're not able to go to work, they're not able to do the normal activities. Maybe they're leaving their kids and not picking them up after school, for example, or losing their job, or kind of becoming estranged from a spouse. Risky use means using in an unsafe environment. So if that's outside, someone's unhoused and they're using, that's pretty unsafe. But also continued use even when people know that they have health consequences. So you can think about those folks that you see who may smoke and they've been smoking for 50 years, and they know that it's leading to their death, but they still are unable to quit. And then the physical dependence is kind of the next step. So after someone has been having all these increasing effects on their behavior, the body also develops a dependence on the substance. So with opioids, for example, it is a very high physical dependence, and it's really easy to become dependent, and then that shapes behavior. The physical dependence that develops with methamphetamines is very significant as well. Basically, a lot of it has to do with, I showed you those dopaminergic cells and how much more of an effect methamphetamines causes. So you can imagine that your body can only keep up with that level of stimulation for so long. So eventually we adapt. And so that means that it takes more and more of that dopamine to have that same effect that it did before. But then also there's withdrawal effects. And withdrawal effects, people will say, oh, there's no withdrawal effect from stimulus, but that just really isn't true. It's a little bit extended. It may not be as prominent or dramatic as things like opioid withdrawal are, which can be very rapid onset and quite distinct. But it is something that can last a very significant amount of time and continue to affect people who have stopped using stimulants for quite some time. Go ahead. So as we think about the levels of stimulant intoxication and the things that we're going to be seeing, so with the increasing dose or potency, frequency of use, the amount that's in the system that is affecting the body, the more likely you are to have these different effects. So, people take these medications when they're, for example, prescribed for more attention. Many people, probably many of you, have had coffee this morning to kind of help you be more awake, more ready to face the day. You may, as people continue to increase the amount of psychoactivation or frequency of use. So you can think about even someone who's smoking a lot of cigarettes, hyperlocomotion, they're going to be maybe a little jittery. You have you have a pot of coffee, you're going to be feeling kind of like that, a little bit uncomfortable. Maybe your body just isn't feeling well. But other more potent stimulants will eventually lead to the things that people are using these for. It's they start to feel really high. They start to feel really, really good. But also, when someone is feeling more confident or they feel like they have more power and they're starting to feel a little bit paranoid, think about the unhoused people, especially you can think about unhoused women or the elderly who are more vulnerable. And it's really useful when if someone is unhoused to not require as much sleep, to to have more energy. Maybe you don't need as much food, your appetite's suppressed a little bit. Maybe you're more paranoid, so you're more likely to see any threats that may be coming at you. But as you increase past the point of fun, past the point that people are wanting to get, you run into the symptoms of overdose, or what's called overamping. And so those are things that affect both psychological and physical problems. And so I'll talk more about them, but basically going from the high of stimulants to psychosis, hearing voices, feeling really confused, not being able to identify with other people, that starts happening. You can go into a coma, which basically, if someone falls asleep and it seems like they're overdosing, but they're breathing, it may be more of a factor that they've had a physiological effect from methamphetamines. And eventually that can lead to things like stroke and heart attack, things like rhabdomyolysis, which is adverse injury to large muscle groups. It can lead to kidney failure and all sorts of things. But a key thing is there are some drugs where it's pretty clear when someone is going to have enough to cause an overdose. So similar with alcohol, but also with opioid overdoses. But the problem with stimulants is that it's not as closely tied. So someone could be using the same amount of the same strength over time, but there could be like one last time that they use that same amount, and this is the time that they have a really serious event. So go ahead. I wanted to mention stimulant withdrawal. As I mentioned, this can have pretty extended effects. So in the acute phase, people are wrecked. They're asleep. They're just extremely tired, and they're kind of shut down. They're really, really hungry. But after that kind of like just shut downness, there comes a point where they start to have a little bit more, movement, a little bit more energy, but they're still in a time where they can be pretty profoundly depressed. So in that first 0 to 10 days, there's a very high likelihood of suicide. And that might be relevant for you if you're seeing someone who they stopped using methamphetamines, but they are being acutely suicidal. That may be a symptom of a withdrawal from methamphetamines. After that, you get into more of a protracted phase. And this says, 1 to 6 months, but I've seen it last 12 months. The literature shows people up to 18 months where their sex drive is down. They just feel totally scattered. They can't concentrate. Their ongoing depression and anxiety makes it hard for them to just participate in life for quite some time. And that's directly related to the methamphetamines that they were using. Continue. So what do we do? How do we think about people who are actively using? Go ahead. So as I mentioned, overamping is the psychostimulant equivalent of overdose. And this is the thing, there's a couple slides here that I think are really important. And I want the next few are the ones that I really want everyone to pay close attention to. As I mentioned, there's both physiological and psychological symptoms. It is an emergency with potentially life-threatening complications. And as I mentioned, it occurs along a spectrum, and people can experience varying levels of overamping. So go ahead. So physically, what's going on? Someone may be having a headache, and it can be the worst headache they've ever had in their life. They may be feeling nauseous. They may be, gritting their teeth, bruxism, like they just can't stop doing it. Choreiform movements means uncontrolled, kind of irregular movements of the body, the face, the neck, the hands, the legs, and they can't stop. So even if someone is being told to stop, because they're acting weird, someone comes up or the police are coming to engage with this person. These are movements that someone can't stop. They're neurologically bound, and so they're beyond that person's power. Cause a lot of dry mouth. Blood pressure can be really high. Hyperthermia is another thing, and that's another thing that can be very, very dangerous. You can imagine so hypertension and tachycardia and chest pain. I mean, these are all definitely cardiac issues. And an important thing to know is that both cardiovascular disease in general, but both cardiac like heart attacks and strokes and weird strokes can happen in people who seem like they are not in the right age range for these sorts of things. So in their 30s, even in their 20s, you can see people having real heart attacks. And so that's why this is such a dangerous thing. You can have seizures. People can feel, just like they're unable to get their breath. And then again, they may pass out, but they're still breathing. So that is just a different than with opioids. So continue. Psychological signs, these are the things that may actually be the most distressing to someone, and actually the reason why they might seek out care, either in emergency rooms or by calling 911, or the things that drive the people around them to do that. So paranoia is a really big one, where people feel that others are out to get them. Like I've had patients who said, they were running away from crowds of people who were threatening to kill them. They may be feel like they're being chased by monsters. They may, who knows what it is. It may be as simple as they think the people around them are trying to steal their money or withholding things from them, or they just think that they know that the people around them know something and they're not sharing it with them. And so that is also called a persecutory perception. So they may be looking at a person, but the way that they're interpreting that person's, the way that they're interacting can be very suspicious and cause a lot of interpersonal, difficulties. So altered perception of reality is another way of talking about hallucinations. And so people will hear things that others are telling them. They are seeing things other people don't, and then that they may be experiencing tactile issues. So they may be saying that they feel the sensation of things coming out of their skin, or just their skins is really, angry. Like I have had people who've called 911 because they're concerned about like new rashes or just weird things that are happening in their skin. And it feels real to them. That's the other thing. This is an altered perception of reality. They're not lying. They're not making it up. It isn't just in their head in the way we normally think of that. These are neurological changes in how the dopamine system is allowing them to interpret the things that they're experiencing. It's important to remember when you're talking to these folks that almost all of them who have severe stimulant use disorders have had major trauma in their life. So, it's just an important, as you're thinking about engaging with folks, being calm and respectful of them, regardless of how, their experience is looking to you, is really important. It says protective behaviors here. This is another really important thing. Remember that they may be experiencing things that are deep threats to them, that they think are signs that something's out to get them, that they're going to be killed, that maybe a monster's trying to get them, or the people around them are really, that just came to try and help, are threats. So they're doing things that everyone else might do if you were under threat. So fight or flight. They may just be really pulling back. They may be very aggressive in how they're speaking, but those are signs of an underlying distress. They're not a sign that this person feels like they're invulnerable and now they're just rage filled or something like that. So be thinking about those things that you're witnessing as protective behaviors. They are altered in how their brain is functioning, and so those protective behaviors may not be very effective, but that is the goal of their behavior. Continue. So what these are, other things you could see, just kind of hypervigilance, so they're not sleeping as much. They can get very panicky. So, you've probably all seen people, I can't catch my breath. My heart's racing and things like that. So it can be that, but it is always important to know if methamphetamines are involved with, if you are getting a call about someone who's panicky, because that just maybe will heighten your thoughts about, hey, we need to make sure we're checking blood pressure. We're doing some of these other things to just make sure that the person's okay and that, this is a reasonable situation. they increase sensory awareness. So that's another one that's probably pretty effective. So that means they may be more tuned into sounds or things that are, very faint changes in color or movement, things like that. So they're going to immediately react to things that other people don't find to be a threat or aren't really even noticing. This kind of defensive posturing or guarding. I think you all know what those things kind of mean, but as someone maybe crouching down, it's important to just remember you don't want to be just standing and towering over them, probably. Um, Go ahead. So, what are the reasons someone might have an overdose of methamphetamines? So, as I mentioned, the type of stimulant, methamphetamine being probably the most powerful stimulant that we know, the amount they're taking, how they're using it. So, methamphetamines is primarily smoked or injected. Most people do smoke, but injection is much more powerful in terms of how rapidly methamphetamines is delivered. Go ahead. So duration of a binge. So this is another thing. So cocaine has a short half-life. People may use for a couple days, every couple of weeks or months. But with methamphetamines, the way it's structured, it lasts in the system instead of a couple of hours, it lasts up to 12 hours where it has its most acute effects. And people are staying up and they're continuing to use, and that often is more like 5 days. So you're starting to run into the problem of insomnia and the things that are related to that. You get to where people, because of those sorts of events and the changing ways that the dopamine system works, they may get to where they are just having to use methamphetamines on a daily basis just so they can stay, more normal and do their normal activities. And it is important to remember that there's a close association between things like trauma, things like being part of underprivileged or under-accessed communities, and things like heart disease, psychiatric illness. ADHD is actually very common in stimulant use disorder populations. Go ahead. So we just tell people, we want to make sure that people know that if someone is behaving erratically and it appears that they have had that they are overdosed on stimulants, that this is a dangerous situation for them, that this could be a life-threatening scenario. Clearly for other people, it's important anytime that there's a heightened engagement that can be pretty a dangerous thing for everyone. So the way we just talk about it is, making sure the scene is safe, see how the person's doing. Are they being interactive? Are they being really aggressive? Or what's going on? Calling 911. And when we talk to people about calling 911, it's important to relay that this is a medical emergency rather than someone who's acting aggressively and erratically. Even if that is, part of what people are seeing, we want to make sure that you or paramedics are the ones who arrive rather than necessarily the police for this situation in many cases. We will talk a little bit about de-escalation, and then also making sure that people know to stay with that person until other people who arrive who can help more. And then this is a scenario where it can be really easy for people to fall into cardiac arrest, and CPR is very important. Go ahead. So target basic prevention, we want to avoid having people develop this problem. So certainly we would love it if everyone could just stop using drugs of all kind, right? But I think we all know, even in our own lives, that can be a challenging thing to do. The more we can help provide things on a community level basis, such as stable housing, support for families, making sure people have what they need in terms of physical and psychological health, are really important. Even things just like, yeah, helping people be clean, helping them have water or a little bit of food, a place to rest is important. Go ahead. So we can. I guess it's important to remember that there are other things that may be going on for people that are using stimulants regularly. So as I mentioned, there's a very it can be common that they are co-using fentanyl, and so making sure that they are aware of that and making sure that they have naloxone, Narcan, being aware that there's higher rates of things like hepatitis or HIV in this population. So doing what we can to treat those things is of course important, but it's also important for you as you're interacting with these folks. Go ahead. A good thing about treating this is there's a reduced amount of crime associated with behaviors around stimulant use. So this is a pretty interesting slide. So on the left, no amphetamine use. Someone has not used, so that's like most populations. But 1 to 15 days of methamphetamine use or 16 days of methamphetamine use. So you see dealing, fraud, property crime, those increase with the amount of methamphetamines, so and the amount of days that someone is using. So, but if they're able to reduce their use or stop, then the level of criminal behavior drops as well. Go ahead. So regarding like de-escalation, this slide is maybe the most important slide of this whole thing for you. So you get called, you go out, you're seeing someone who's acting in an erratic way. You get the information that they've had methamphetamines, and it's like, wow, they've used this before, but they've never had this kind of response. We don't know what's going on. So we want to try and figure out if they're like seeing what's happening in the scenario. Like, is there something specifically that the person is responding to aggressively, or is causing some agitation? Is it a safe environment? Are there any needles on the ground, or is there a weapon involved? Things like that. You want to just see if you're in. And a really important thing to know is the more you can be calm and speak slowly and with and respectfully to this other person who is in a very dangerous situation, that can really help cool them down too. So just trying to do what you can. Also be aware, and this is just another good piece of advice, when you're in this situation, it can be really heightened. It can bring up a lot of emotions and kind of physical responses for you, a lot of adrenaline and things like that. So just being aware of how you are feeling and how that might be affecting your behavior in interacting with this person. Remembering that they are very cued in to like all of the things that you may be doing physically, that you're communicating with them that are outside of the words that you're using. So the more you can try to really work on being calm in your body, the better things are going to go. It's good to be calm and just direct when you're communicating with them. Asking some questions about what they're doing and listening to their response is important. Now, that doesn't mean that you're kind of feeding into whatever scenario they're responding to. But if they're saying, God, they're chasing me, that guy's trying to kill me, stuff like that, that sounds terrifying. And I understand that that is affecting you, and we're here to help. And, things like that are an easier way to respond. And that may actually help them if they know that you're really trying to help them. So as you're going through this, you're going to be watching to see how the things that you're doing are affecting this person. It may be that what you're doing is actually making them feel worse. I read a thing about someone who was trying to like get down on someone else's level to just so they don't feel all big and a threat, but it was in a room where the person didn't feel they could get out and they could get away, so the closer the person got to them, the more threatening it became. Then if they start to feel better, they start doing better, trying to reinforce that, maybe giving them something to drink just while they're calming down. That may just say, let's have a seat, let's just be here and be calm. Go ahead. So yeah, always be aware of your safety, and don't approach a patient if they have a weapon. But remember that even if they do have a weapon, that doesn't necessarily mean they have the intent to use it. It may be just part of their protective gear. That may not even be part of what they're dealing with. So even if you see that, that does not need to necessarily change how you are interacting with them. And the more you're able to stay calm, the less likely they are to use it. Go ahead. A few other things, avoid staring at them, try not to corner them, sudden behaviors. So try and make sure that you're moving calmly. Try and see if there's a lot of sound or a lot of people, trying to keep it as calm as possible. And then open-ended questions, and just make sure everything is safe. Go ahead. I recognize I only have a few more minutes, so. Um, so as I mentioned, I kind of mentioned some of these sorts of things. So yeah, if I had bugs crawling out of my skin, I would be very uncomfortable. You know, sounds scary if someone's chasing you, things like that. So just responding, like you can even reflecting. So saying exactly, if you're just like, this is really weird, you know, just saying back what they say to you, just mirroring can actually be a very effective way to help people calm down. You know, they're saying, you know, I'm feeling really scared, or I'm super upset at that guy. You know, I hear that you're super upset at that guy. You know, that can actually be something that helps people calm down. Go ahead. So there's no antidote to this overamping, but benzodiazepines are extremely important. They are the first line thing that will benefit this person both psychiatrically and also physically. That can help even when they're having elevated blood pressure. It can happen with all of the signs we talked about. Benzodiazepines are the first. Second line antipsychotics, but really on a longer term basis, that may be useful. But in the moment, it's perfectly reasonable to give someone some antipsychotics that will hopefully just kind of help them cool down a bit. Um, but you're not just treating that, so that will help them calm down. But if there's a heart attack, clearly that's, you know, you still have to be responding to that aspect of what's going on. Go ahead. So a few other treatments. I'm just going to mention these briefly. Go ahead. You know, as I mentioned, just overdose prevention, making sure folks have Narcan, that they know how to use it. I think that for you guys, that's really the most important thing. And then just being aware of other things like infections or other illnesses they may have, including things like COPD, breathing issues really early. So just be aware of those. Go ahead. So there's no FDA approved medications, but we are working on finding some of them. They have some evidence. We need a lot more evidence, but you know, long-acting injectable antipsychotics have been shown to be pretty good. There's a couple of other antidepressants and things like that that we use. To talk for another day. Go ahead. An important thing to know is that something called contingency management, which has been shown to be very effective at helping reduce use. So it actually has been shown to reduce the risk of death in a population that adheres to like a 3-month program. It reduces risk of death from stimulant use disorder by over 40%. From baseline, which is massive. There aren't very many medicines aside. Things like buprenorphine and methadone have a similar, a larger effect than that for opioid use disorder, but there's really almost no other medications that we prescribe for any disease that have that same level of effect. Go ahead. So I think we can just skip the last little bit of this right up, and if you can skip a few more, Sarah. These are just slides specifically about contingency management. Go ahead. Yeah. Keep going. Keep going. Okay, stop. Okay, so we have a lot of people who use stimulants, and it has been continuing to rise. It's a big part of what populations are dealing with. There's lots of things that you can do that can make these encounters less distressing for everyone, and more likely to have positive outcomes. We are developing new treatments, so it is true that these are things that are this is a medical condition that is very serious, and it also does have some treatments that are very effective. So this isn't like someone is going to be this way forever. They're not just a tweaker, you know what I mean? Like, so they're a person with a stimulant use disorder, and that is something that they can recover from. So there you go. All right, 10:59. And this
Well,
is
that was, excuse me, that was really good and very interesting, and a good, that's really a lot of information. Before I ask I always ask a couple questions. I want to make sure that if anybody has any questions they want to unmute or put it in the chat, I'll be happy to uh, ask the question for you. Does anybody have any questions in the audience? Not seeing any. Okay. So here's my question for you, Shannon.
Yep.
Yeah, you talked a lot about well, you talked about in our EMS environment, the stimulant toxicity can present with agitation, tachycardia, and hypothermia. Yeah. But from your perspective, what key assessment findings for us at the scene or seeing cues would EMS focus on quickly to differentiate between a stimulant overdose and maybe a psychiatric or we can talk about opioid, but we understand, but I guess some psychiatric or other medical conditions.
I think that, so elevated blood pressure, like highly elevated blood pressure, if they are having symptoms of chest pain, things like that are important. It may look different than someone else who's got another psychiatric condition that's leading to those sensations. But I think the physical signs, the jaw clenching, the unable to stop moving, things like that, pacing, those are things that may be kind of separated out a little bit more for you.
And one last, I guess, question is, as we've been focused on for the last few years about the opioid crisis and fentanyl and all that, but stimulant use is probably on, as you mentioned, it's on the rise, and it's also being mixed in as well. What role do you think EMS can play in the public health role regarding, I guess, harm production or harm, not production, harm reduction? Let me try that one again. And maybe do some public education and try to, I guess, improve patient outcomes. I guess that's three different questions all in
Yeah.
one.
Well, I think that there's in the acute moment of when you're seeing someone, kind of changing how maybe you're thinking about things and then how you're responding to that individual. It may be that the things you're doing for the moment are going to remember and may start to change the way that they think about their interaction with healthcare providers in the future, or even their own health. So every time you interact with someone struggling in this way, there is the potential that you could play a role in them getting better, because you're seeing them at the worst, the worst day that they ever had their whole life. And so like Groundhog Day, one thing. Another thing is just really trying to use the words in the way that I'm talking about can be really useful, both at work, but also at home or in more social environments. It's a good way to help the population as a whole recognize a little bit more that these are people in our community who are struggling with a really serious illness, and that they need support and not ridicule and not shunning, and that there are effective ways to help them with the corrective support. So the other thing I will just say is, supporting any movements toward providing funding for housing, psychiatric support, things like that for this kind of population can be really helpful. Hopefully that will help avoid future generations being affected in the same way.
Well, those are great answers, and I really want to appreciate you and Sarah for presenting this for us. I do appreciate it, and I want to thank you very much. And there's been no other questions in the chat or anything, so I want to say everybody have a good rest of the month and happy Halloween.
Last thing, I just wanted to mention that there was a QR code at the end, and if you guys could just take a look and do a quick, just answer questions, really, really helpful. Help for me, what I can do better, and just helpful for the program as a whole.
All right, it's fantastic. Okay, maybe you can send me that QR code and I can put it with the video as well as a show note.
Right.
All
Thanks,
right.
everyone. Appreciate it.
Thank you. All
Bye-bye.
right, everybody. Have a great day.